Dr. Tippett's going to come back up and finish our tour of the left-sided valves with a talk on mitral stenosis and AI.
So, like we've been talking about, we've got a watering can in the left ventricle, and this is an awesome picture. I've never heard the left side of the heart described as a watering can before, but when I look at this image, this is exactly what I see. I see inflow from the left atrium into the left ventricle coming out the aorta through the LVOT. This is a perfect demonstration of what we've been talking about all day. So what we're going to talk about right now is when you have altered function of the mitral valve, and it's stenotic. So we talked earlier about regurgitation, which is much, much more common. We'll talk a little bit right now about stenosis, where you have abnormal inflow into the LV. And let's see if we can get this other one to play as well. Nope, that's okay. All it's going to show is opening of the mitral valve from an atrial view, and it's going to show what we were talking about earlier about the outpouching or the dilation of the left ventricle posteriorly, and you can see our anterior leaflet. Hey, there you go. Thank you. Anterior leaflet here, posterior leaflet here. So mitral stenosis, which you see here on the right, is narrowing of the mitral valve. Abnormal inflow from the left atrium into the left ventricle can happen for a number of reasons. Most common reason worldwide is rheumatic heart disease. Group A strep infection leads to rheumatic fever. When left untreated, 3 or 4 decades later, we start developing rheumatic heart disease. We can have involvement of multiple valves, but one of the most common valves to get involved is the mitral valve. And so we can see mitral stenosis. We can also see some component of mitral regurgitation. The other common cause for mitral stenosis that we see most common in the States is calcific or elderly mitral stenosis, which when you look at it worldwide, its proportion compared to rheumatic disease is really, really small. 90-some-odd% of mitral stenosis worldwide is related to rheumatic disease. But what we see here in the States is typically related to calcific disease, and there's important differentiations to be made because of those, because the treatment for those two types of stenosis can be different. So mitral stenosis was the first valve lesion successfully treated with surgery. This was reported from the Boston Medical Journal in 1923. It was the first disease diagnosed using echocardiography, and it was the first valve lesion successfully treated with percutaneous balloon valvuloplasty, still an important modality in treating mitral stenosis. And worldwide, it's the second most common valvular lesion in developing countries. So let's jump into rheumatic mitral stenosis, the most common, described as having a fish mouth appearance of the mitral valve. I think you guys can probably appreciate that. You have fusion of the cusp and a typical hockey stick appearance of the mitral valve leaflet. So here we have an anterior mitral valve leaflet and a posterior mitral valve leaflet over here from an apical 3-chamber view on TTE. And you see hockey stick appearance from fusion of the anterior lateral and posterior medial commissures of the mitral valve. Again, we have some TT images here of mitral stenosis. We'll see if we can appreciate any reduction in leaflet motion here in each of these, in a fish mouth view and a short axis view of the left ventricle. Compare that to the disease process that we see in calcific or elderly mitral stenosis, where you have calcifications deposited usually more around the annulus. They can be on the leaflet themselves, but typically mitral annular calcification is more commonly seen as patients get older here with a Western diet and the anti-inflammatory effects that we see because of that, compared to the mitral commissural fusion that is seen in rheumatic mitral stenosis. So different disease process treated a different way. So the hemodynamics of mitral stenosis are that you have elevation and dilation of so you have elevation of the left atrial pressure and dilation of the left atrium in response to stenosis and of outflow through the left atrium into the left ventricle. You can have reduction in the pressures in the left ventricle and on out into the aorta as well. These pressures can be transmitted in a retrograde fashion into the pulmonary system and lead to a variety of symptoms, including fatigue, shortness of breath, etc. How do we grade mitral stenosis? So you can do it with a number of different methods. TEE is one of those, TTE as well. We can determine a mitral valve area. We can determine a mean pressure gradient. We can also determine the mean pulmonary artery pressure. And if the mitral valve area is less than 1 centimeter squared, it's considered severe mitral stenosis and should be treated. Mean pressure gradient's debatable, but somewhere around 10 to 12 range. Anything over that is considered severe stenosis. Anything less than that, moderate, 6 to 10, 6 to 12, and then below that's considered mild. So how do we treat mitral stenosis? Well, there's a couple of different ways. The most common way that mitral stenosis is treated in the U.S. is actually with percutaneous balloon mitral commissurotomy. So the way they do that is on the left-hand picture here, you have a stenotic sort of fish mouth mitral valve they put across a balloon, which you can see dilated here in this nice 3D image, which splits open the commissures, and here we are in diastole with filling the left ventricle looking down from the atria. You can see a nice wide open mitral orifice area, and you can see a decrease in the mean gradient from before and after treatment. So we have severe mitral stenosis with a mean gradient of 10 pre-treatment or treatment, and then afterwards we have a reduction in mean gradient. So how do we actually measure pressure gradients? As we were just talking about a second ago, you can shoot a continuous wave Doppler through various different places, and you can calculate mean gradients or pressure gradients all throughout the heart. For the purposes of mitral stenosis, we would shoot a continuous wave Doppler through the inflow of the mitral valve leaflets. We can get that in a number of different places. 4-chamber is a fine place to try to do that. Once you get your continuous wave Doppler flow pattern, you can just pause that image and trace that out, and the computer is amazing. We'll do all the work for you, and you can get pressure gradients just spit right out onto the computer. However, there are some pitfalls to measuring just mean pressure gradients. High flow states or high flow rates can lead to an elevated transmitral pressure gradient, even with only a moderate degree of valve narrowing. So if you have tachycardia, mitral regurg, or you have an increase in left ventricular volume, anemia is a high flow state. All those can lead to falsely elevated transmitral mean pressure gradient. Low flow states can lead to low transmitral pressure gradient despite having severe mitral stenosis, so a low stroke volume state or bradycardia. You can also have beat-to-beat variability, like in atrial fibrillation, where on one beat you may appear to have mild mitral stenosis, on the next you may appear to have severe mitral stenosis, just depending on which beat you measure a mean gradient on. And also, if you have an increased angle between the mitral stenosis jet and the ultrasound beam, you can have alterations in your pressure gradients. So here's an example of how we do that. So you get your continuous wave Doppler profile, you trace that out, you get a mean gradient of 5, so no big deal, mild mitral stenosis. But while we're here, why don't we go ahead and check another way to determine if we have severe mitral stenosis, or just grade the mitral stenosis. Let's do a pressure half-time. So we can take the same tracing, do a pressure half-time, and we take 220 and divide that by the pressure half-time, and now we get 1.2 centimeters squared, which would be moderate mitral stenosis. So what gives? We have one reading that says it's mild, another that says it's moderate. So the thing that we have to notice on this last picture, I don't know if you guys can see it, but I'll give you the hint. It's the heart rate is 49 beats per minute. So your mean gradient when evaluating mitral stenosis can be affected by a number of different things. Like we talked about, high flow states, tachycardia can affect your mean gradient, falsely elevating it. So what we have here is, say for example, a normal heart rate, 70, something like that, and we have pretty significant mitral stenosis. So moderate almost all the way to severe mitral stenosis, reading 9 millimeters of mercury. But if we have an increased heart rate, say it's 110, 120, we'll almost certainly have an elevation in our mean gradient. However, if we're bradycardic and our heart rate's 49, we may have a mean gradient that only comes out to be 4 according to the mean gradient calculation on the computer, all because of reduction in flow or an increase in flow, all due to heart rate. So when evaluating mitral stenosis using a mean gradient, we have a mean gradient of 12 at a heart rate of 110. Or we have a mean gradient of 9 at a heart rate of 70. You've got to include those other components as well. Another way to determine severity of mitral stenosis is using planimetry. Not the most accurate method to do it. I wouldn't recommend doing it unless you're going to use 3D, but that can be done as well. The way you do that is just take a short axis view, look for the most wide opening of the mitral valve and trace it out, and the computer will spit out a number. The problem with that is that you have poor image quality usually. You can have deformed valve anatomy. You may not have the proper place to measure the actual orifice opening, and so you may over or underestimate the actual smallest orifice area. So the other way we spoke about measuring or grading severity of mitral stenosis was using the pressure half time. So you can divide 220 by the measured pressure half time and determine the mitral valve area. And so here's an image of how you actually do that. You take your CW tracing through the inflow portion of the mitral valve, trace that out. You need to have a straight line, and you divide by 220. And if it's more than 220, it's severe mitral stenosis. 150 to 120, moderate. Less than 150, usually mild. There are limitations with that as well. Beat-to-beat variability with atrial fibrillation can interfere with an accurate measurement. Aortic regurgitation, which is another high flow state. Changing LV and left atrial compliance, and non-linear earlier diastolic velocity slope. So that's pictured here. So you have an early sharp phase. I totally stole this slide from Stephen Little, by the way. Thank you, Dr. Little. You have an early diastolic filling here, and if you were to trace this slope here, you would have severe mitral stenosis, but you actually want to take the longest slope that you can. So you need to have the same slope over 50% of the tracing. So you want to take the bunny hill, trace that, not the black diamond. Here's two other contraindicated things that you shouldn't be trying to trace out, where you have rapid change in the slope of a tracing, either one way or the other. Neither of those is going to give you a very accurate reading when trying to grade mitral stenosis. So, using pressure half time, here's another example. So we have a pressure half time of 79. We take 220 divided by 79. We get like 2.8 centimeters squared. So nothing. Insignificant mitral stenosis, no big deal. But being the good doctors that we are, we're not going to stop there. We don't believe it because maybe the patient has symptomatology that's consistent with mitral stenosis. We can take another measurement. We can use the continuity equation through the mitral valve and determine the mitral orifice area using a combination of measurements through the RVOT. So the cross-sectional area of the RVOT times the time velocity integral through the RVOT divided by the mitral inflow or time velocity integral. And that would give us 1.45, so moderate mitral stenosis. So again, a huge difference, all in the same patient, same tracings. One tells you you've got no mitral stenosis, the other tells you you've got severe. So what gives? There are limitations to each and every one of these ways that we measure. So continuity equation used to evaluate mitral stenosis, again, atrial fibrillation, aortic regurgitation, mitral regurgitation, all of these things are going to alter the reliability and the accuracy of these measurements. So what we do in real life is we take our best guess. So based on the symptomatology, based on our best 2 or 3 estimates, which of these correlate with what we think is going on, and that's the one that we use. So here's just another example of effective heart rate. Same thing we saw earlier with a mean gradient. So a normalish heart rate, 70 or so, can have an elevated mean gradient. You increase the heart rate, gives you an even higher mean gradient. However, the opposite happens when you're looking at your time velocity integral. That causes a reduction, and that's the denominator in our continuity equation, and so that will alter our mitral stenosis calculations just as it did for mean gradient. I'm trying to advance. There we go. Skipped a few. That's okay. I'm going to skip ahead a couple because I've only got like 5 minutes left, and I still have to talk about all of aortic insufficiency. No, it's okay. It's okay. This is good. So if we have symptoms with mitral stenosis, we do an echo. Hopefully the echo is going to correlate with the symptoms. However, if it doesn't, if we have severe symptoms, we have an insignificant gradient or a calculated low valve area, we do an exercise Doppler, see if we can elicit a proper gradient when we have normal flow conditions. So should you have to do a TEE to evaluate initially for mitral stenosis? No, usually not. Only if you're going to do a pre-balloon valvuloplasty or grade the amount of mitral regurgitation, and you almost never have to do a catheterization anymore, which used to be the very common thing to do. So the most common way to treat mitral stenosis is with a balloon valvuloplasty. So there's an index used to calculate whether or not you're going to be successful when doing valvuloplasty, and it's called the Wilkins Index or the Splittability Index. And so can the mitral split? So calcification, thickening, mobility, and the subvalvular apparatus. Each of those is given a score, and if it's greater than 10, they're considered unsuitable for percutaneous valvuloplasty. If it's less than 8, then you go ahead and give it a try. This is a really small slide, but the gist of what it's saying is most of the time you're going to be doing percutaneous mitral balloon commissurotomy to treat severe mitral stenosis. Essentially, the only time you're going to have a surgical intervention is when you have a valve that has some reason that it can't be split. So we were talking earlier about rheumatic versus calcific mitral stenosis. Calcific mitral stenosis, because you don't typically have fused commissures, aren't prone to being able to be split apart. If you balloon that valve open, all you're going to do is just like if you balloon open an aortic valve that's calcified, you're going to smush that calcium deposits into the annulus of the mitral valve. You're not actually going to fix anything. However, if you have a fused mitral commissures from rheumatic disease, you can actually split those open, and they should hopefully have near normal function afterwards. So let's switch gears. All right, this is the whole story right here, one slide. Acute versus chronic aortic insufficiency. So acute AR, you're going to roll down the hall and they're going to be sick as snot, and hopefully you're going to be fixing them soon. It can happen for a number of reasons. We'll get into why aortic insufficiency can happen. However, chronic aortic insufficiency happens in a lot of people, and those people are the ones out on the golf course still kicking around like 9 years later. So acute aortic regurgitation, endocarditis, type A dissection, traumatic, pretty rare, but can happen. Really, it's endocarditis and dissection that we really see surgically. Patient tends to appear acutely ill. They may or may not have a murmur. They typically have a normal or low systolic blood pressure. When we see them come into the OR, seems like the ones I see are always low, and they tend to have a wide pulse pressure, which is depicted here. Normal aortic waveform here, where you have a nice diastolic pressure that elevates during systole. In aortic regurgitation, you have this reduced way down. And you have abnormal coronary perfusion during this diastolic phase, which is extremely low, which is one of the reasons these patients can appear so critically ill and tend to circle the drain. So management of acute aortic regurgitation, patients are usually very symptomatic. Vasodilators may help in the short term, can augment forward flow with inotropes if needed. Use of a balloon pump is typically contraindicated in the hypotensive patient, and aortic valve replacement is typically required. Now, chronic, why does chronic happen? It could be for a number of reasons. Chronic aortic insufficiency can be from bicuspid aortic valve. A number of collagen disorders can cause that. You can have dilation from an aortic aneurysm. A whole number of reasons. So you have varying severity. You can have a long asymptomatic period for years, typically. They typically have an insidious onset of symptoms. They tend to have an aortic insufficiency murmur, and you can hear that one. They tend to have an elevated systolic blood pressure, but they still have that wide pulse pressure. I'm not going to go into this, but there's lots of physical exam findings used to describe aortic insufficiency, which I've forgotten like 9 out of 10 of those. So how do we grade that? We can grade that using angiography. We can do color flow Doppler jet width. If the jet width of the LVOT is greater than 65%, that's typically considered severe aortic insufficiency. We can also measure the vena contracta, typically done in like an aortic valve, mid-esophageal aortic valve long axis view. And if it's greater than 0.6 centimeters, that's considered severe. And here are some echocardiographic images, basically just differentiating between mild and severe aortic regurgitation. So here you have a small jet width in the LVOT. Here in severe, much wider jet width, taking up almost the entirety of the LVOT. Hard to see on this picture, but just take my word for it. You can also measure pressure half time, and you can also look at the descending aorta. If you have reversal of diastolic flow in the descending aorta, that's pathognomonic for severe aortic insufficiency. So two live, well, not live image, but two TE images, one of which is going to work. So this one was mild aortic insufficiency, and just for comparison, this is severe aortic insufficiency, where you have complete, almost complete filling. I did a bad job doing the echo, sorry. But trust me, this is going to fill up the entire LVOT. So how do we grade that? Again, we can calculate regurgitant volumes either in the cath lab or using echo. Greater than 60 mLs is typically considered severe. Regurgitant fraction greater than 50% is considered severe. How do we manage it? Mild, almost never needs surgery. Moderate, you may need surgery, it depends. But if they have severe aortic insufficiency, surgery may be needed depending on the symptoms, LV size, so left ventricular end systolic diameter, and left ventricular end diastolic diameter, and function. If you have a reduction in LV function, it might be wise to go ahead and consider proceeding with aortic valve replacement. So this is a picture depicting survival in years depending on the EF. So patients with reduced EF have a shorter survival compared to those with normal EF. So again, chronic severe aortic regurgitation, if they have symptoms, it's a class 1 indication to go ahead and go to AVR. Symptoms tend to progress slowly, 6% per year. If you have normal LV function in an asymptomatic patient, only 6% of those people progress to symptoms throughout the year. Progression to asymptomatic LV dysfunction, 3.5% per year. Sudden death, these people don't die, 0.2%. They tend to live a long time when they're asymptomatic. However, when they have abnormal LV function, progression to cardiac symptoms happens within 25% of people within a year. And if they're symptomatic, they typically have a very poor prognosis, and mortality is 10% per year. So, surgery before LV dysfunction is the goal. Again, this picture just shows reduced EF and reduced survival. Normal EF, much higher survival. So you want to operate on these people before you have reduction in left ventricular ejection fraction. Same thing here. And I'll refer you guys to the 2014 ACC/AHA guidelines to look at all this. But if you have end diastolic dilation of the LV, you should proceed to AVR even if you have an asymptomatic patient. Symptomatic patient should go ahead and go for AVR class 1 indication. So you want to have measurements that are accurate and reproducible to grade LV dimensions and the EF in order to make proper decisions whether or not to go to surgery. Echocardiography must be done using meticulous technique, preferably the same people doing it every time. 2D LV dimensions are superior to in-mode measurements, and consider cardiac MR if available. Thank you.